How do I identify patients that need a quick response, and how is that pertinent to, say, the Javelin 100 phase 3 study that we just saw yesterday at the meeting? So many of our patients, when they first progress with newly diagnosed cancer, stage 4 disease, are symptomatic. If it's an esophageal cancer, they can't swallow. If it's a gastric cancer, their metastatic disease is symptomatic. They have pain, they can't eat well, etc. And so most patients need a response to therapy, at least a clinical response. So that is traditionally why we use chemotherapy as soon as we can, because it's palliative, and the response rate is 40 to 50% with first-line FOLFOX chemotherapy, and another 30 or 40%, well, at least even if they're not responding by RECIST criteria on a scan, they're deriving clinical benefit with improved symptoms. So most patients need a response to some degree. And this is where we get into the immunotherapy studies that have been done, say KEYNOTE-62 or others in second line, where we're starting with monotherapy checkpoint blockade. Certainly in an unselected population, many of those patients, that's not the right thing to do, because they need a response. And if they're going to be a PD-L1 negative patient, their chance of responding is nearly zero, and they do worse than standard therapy. So you're not doing them any favors by using monotherapy checkpoint blockade. Where Javelin 100 comes in, because that was designed as a maintenance study when immunotherapy was introduced, was after a period of 3 months of chemo induction. And so this made a lot of sense in many ways, because we noted that 805 patients were enrolled at the time of starting therapy at newly diagnosed, but 40%, almost 38% of patients weren't enrolled into the part when maintenance therapy started, when the immunotherapy was started. And that's because they progressed or they died and they weren't eligible, they weren't considered stable or responding to the induction chemo. And so this was brilliant, because now you've enriched for the patient population that might benefit from immunotherapy going forward. Unfortunately, that still wasn't enough, at least in all comers without selection by PD-L1 score. You still had a yin-yang curve where there were patients doing worse with the immunotherapy compared to just continued chemotherapy, which was a little bit surprising to many of us, but not if you look at all the prior data. If you look at CPS 1 or higher patients, they seem to be the ones to benefit from switch maintenance to immunotherapy. So in a long-winded answer is that chemotherapy is the right answer for patients who are heavily symptomatic.